Hi, this is George Deely, Vice President of Healthcare Solutions at Dimensional Insight. I'm very excited to be with you here today at the HFMA conference. I wish I could be here in person, but that's just the way things are going these days, right? So I want to talk to you this afternoon about data-driven decision-making. And when I've given this talk in the past, I've relied on familiar topics. Like the last time I was out there actually making this a similar presentation, I used baseball because we were so close to Cooperstown. But this year is a little bit different, right? Now we have something that's quite data-oriented to talk about, that's not only familiar, but also relevant to both healthcare as well as our day-to-day lives. And that, of course, is the coronavirus and the COVID-19 pandemic. So let me start out with this question. How many of you don't use data to make decisions? It's pretty hard not to, right? I mean, whether it's navigating in our cars or making online purchases or just looking things up on the internet, we're getting a big assist from machine learning algorithms running against big data sets in the cloud. But here's my question for you. Are we maybe getting a little too comfortable, maybe even complacent with machines doing so much work for us? We certainly don't need to work as hard as we used to. I at least can remember doing calculations with paper and pencil, maybe even a slide rule. That goes way back. How about navigating with a paper map? I mean, that's not easy by any measure. But with Google Maps, Waze, Apple Maps, we just plug in a destination and off we go, right? But sometimes we don't end up with the optimal result either. It may try to take us out of the way to avoid tolls or keep us off the back roads when we really just wanted to get there on the shortest route or as quickly as possible. But what if we had more insight into the options and played a more active role in the decision? We could harness both the power of machines and our own minds at the same time. So the potential for applying data-driven decisions in healthcare and public health in particular to improve and preserve life is pretty incredible when you think about it. Take infant and child mortality and the work that the Gates Foundation and others have done. Since 1990, the under 5 mortality rate for children has dropped by half worldwide. That's 4.4 million children around the world who didn't die, and even more at this point. This data is a little dated. This was done by consistently applying evidence-based practices that have been shown to be effective in preventing childhood death. So pretty basic things just work when applied consistently, such as breastfeeding until at least 6 months, skin-to-skin contact, essentially holding the baby, keeping the baby warm and dry, disinfecting the umbilical cord at birth. Things that seem pretty basic, but the important thing here is that they're being communicated consistently to the people who can make a difference, mothers and their caregivers. So this is a great example of information literally being used to save lives. But that happened over the course of 25 years. Right now, in the age of the coronavirus, the importance of reliable information is a matter of life or death from day to day. So I want to make the case for a basic set of quantitative skills that I refer to as numeracy. It's the math counterpart to literacy, if you will, that will help you understand and use data like what we're immersed in from day to day with COVID-19. So if you're a football fan, you may have heard of John Urschel a few years ago. He played the offensive line for the Ravens for 3 seasons. He was a star at Penn State before that. But then he had a bad concussion, and he retired from football, that is, to pursue a PhD in mathematics at MIT. Now, not everyone gets into the doctoral programs at MIT. You literally have to be brilliant So you can pretty much assume that he is. Now, he wrote a book about his experiences both in the NFL and as a math whiz. And in it, he made some pretty interesting observations around the fundamental importance of being at least a little bit numerically competent. Even going as far as to claim that being mathematically illiterate is a dangerous thing. Quoting him directly in the book, some people will joke about not being very good at math. People don't joke about being illiterate. That's an interesting perspective. It's certainly provocative, right? Now, he's a true outlier, granted, when it comes to math proficiency. So what is he referring to for the rest of us? After all, most people making routine data-driven decisions from day to day aren't mathematicians, statisticians, or data scientists. You know, they're regular people. Well, maybe he's talking about just some basic but essential critical thinking skills that happen to involve numbers. And that's what we're going to refer to as numeracy. So let's start with a basic example of what he might be talking about. So the probability of A given B equals the probability of B given A times the probability of A all over the probability of B. Right, you say. And there's probably plenty of you scratching your head thinking, what is this? And how could it possibly be helpful to me? But at the same time, there might be some mathematicians or statisticians in the group that look at this and say, oh yeah, that's elementary. That's Bayes' theorem. And this begins to make a little bit more sense if we substitute some different words for these terms. So H is the hypothesis. That's our initial hunch or assumption about something. And E is evidence, essentially data that can help us to support or refute that hypothesis. Now, in Bayesian terminology, we have the prior probability and the posterior probability. And in essence, what that means, the prior probability is that initial hunch or idea and the likelihood of it being true. The posterior probability is an update to the likelihood of that hypothesis as we introduce evidence. And think about it. This is the way that our minds work at a subconscious level, right? We have an idea based probably on some kind of observation, and we update that idea as we encounter additional data or evidence. And we continue to do that. We refine our idea, our hypothesis, until we get something that we're comfortable with. Well, machines, as in computers, can do that really well with data, right? But they don't necessarily do it at a subconscious level. They need to do it in terms of bits and bytes and math. So the thing that's really significant about Bayes' theorem is that it takes what we do as human beings somewhat subconsciously and transforms it into math so computers can actually use it. So this idea of Bayes' theorem is similar to what a lot of machine learning and ultimately artificial intelligence algorithms use. Not exactly Bayes' theorem, in some cases, yes, but a lot of the other algorithms work in very similar ways. Interestingly enough, some of those algorithms called neural networks actually try to emulate that subconscious process of the human mind and looking for patterns and trying to figure things out without knowing exactly what they are. So this is really the basis for the scientific method, right? Going back centuries. In fact, the idea behind Bayes' theorem isn't exactly new. It was initially proposed by several people at the same time in the mid-1700s. And there's a rich history, particularly in healthcare, around how this type of thinking has been used to advance healthcare using evidence and applying evidence in practice. So here's a story from 160 years ago that I've found to be quite inspiring. You may recognize the name Florence Nightingale. And if you do, you likely think of her as the founder, the founding mother, if you will, of the nursing profession, which she was. But she was also a very talented statistician in her own right. She was the first woman admitted to the British Royal Society of Statistics, and she was also a pioneer in public health. Now, one chapter in her life that is particularly relevant to our discussion today. In 1854, Britain was at war to stop Russia's advance into the Crimean Peninsula, which may sound familiar from current events of the last few years. Nightingale was then in her early 30s, and she was charged with leading a contingent of 38 women to run a military hospital in Scutari, Turkey, which would treat wounded soldiers brought from the battlefront several hundred miles away across the water on the Black Sea. And the compassionate care that she and the other nurses provided to soldiers became legend, and she became a heroine back in England, known as the Lady with the Lamp. But despite all of those accolades, there was something that Nightingale couldn't stop thinking about. An inordinate number of soldiers had died not from battlefield wounds, but from diseases stemming from the unsanitary conditions in the hospitals. The British had lost 18,000 soldiers, almost an entire army. The Crimean force was intended to only number about 25,000. Most of those deaths had come from preventable illnesses. So in analyzing the data on the causes of mortality after the war, Nightingale discovered that many of these deaths were the result of conditions in her own hospital in Scutari. The noxious fumes from the backed up sewers under the hospital and the poor ventilation, the windows couldn't be opened during the frigid weather in the colder months, were actually killing patients. Wounded soldiers actually would have been safer in the primitive regimental field hospitals than in her own. Now, this was far from obvious. Certainly during the war, they would have done something about it. So how did she figure it out? Well, the truth lay in the data, and it emerged with careful analysis and incisive interpretation. Now, the graphic that you see on the slide here, called a rose chart, is a forerunner of what we think of today as the pie chart or even the donut chart. And that was part of Nightingale's report to the British government, showing how the pattern of deaths ebbed and flowed with the seasons during the 24 months of the war. Remember not being able to open the windows during the winter? Well, that played into it. So this was an early and very effective example of using pictures to communicate data. Now, that truth actually drove Nightingale into a deep depression that confined her to her bedroom for the better part of 10 years. But her passion to improve public health inspired her to use the experiences learned during the Crimean War to reform first the sanitary conditions in the peacetime military, which had a death rate considerably higher than the civilian population, and then in the slums of London, where cholera outbreaks from bad water and the death toll that came with them were fairly routine. Now, the impact of those improved sanitary and other public sanitary conditions and other public health practices that Nightingale helped to define and promote have been felt well into the 20th century and beyond, now into the 21st century, both in Britain and around the world. In fact, you can see in the response to the COVID-19 pandemic some of the practices that Nightingale pioneered in the mid-19th century. And think of it, all this was done long before the advent of computing or electronic data. So it underscores some of the essential ingredients of data-driven decision-making. Passion. Nightingale certainly had that in spades. Curiosity, careful analysis, and persuasive communication. So fast forward to 2020. We have all this data for COVID-19, right? So on the screen here, you're seeing in Excel form statistics from just a few days at the county level of the most basic statistics in Massachusetts. Massachusetts doesn't even have many counties. I think 11. So this is really just scratching the surface in terms of the amount of data that we have available to us. But even in kind of a small data set here, it's just a jumble of numbers. There's really nothing that kind of sticks out here aside from the fact that some counties have more cases and more deaths than others. So how do we even begin to make sense of this? Well, we can use some of the essentials of what we're referring to as numeracy to dig in and understand things, quite similarly to how Nightingale did it 150 years ago with a lot less technology. So here are the things that we're going to talk about during the rest of this presentation. So first we have data, the evidence. We can't do any of this without trustworthy, reliable, interpretable data. Then there's analysis. That's how we make sense of the data. And part of that is visualization that helps us to very quickly understand that we need the help of pictures to understand data and with our analysis. And then why are we doing this? You know, critical thinking. What conclusions can we draw? And what do we in turn do with that? And then communication. Once we've figured this all out for ourselves, how do we convey it to others and motivate them to action? So let's start with data. Some of the essentials, some of the terms that we need to be familiar with in order to understand the data that we're going to use for analysis. And I've picked out 3 things that I think are particularly important to understand. First, we have what are known as categorical variables. So they are the non-number data, words typically, things like state and county. Then we have our quantitative variables like cases and deaths. Cases and deaths are the raw data, right? They're about as basic as we can get. But we need some context to understand what they really mean. So then we have a subset of those quantitative variables that we refer to as or measures, or you may have heard them as KPIs or key performance indicators. An example of that would be cases per 100,000 members of a population. So we're going to take a look in an analysis tool, and this happens to be Dimensional Insights, a ProDiver analysis tool. We'll also use examples from Excel and some open source tools as well. But the first thing we're going to look at is what I just mentioned in terms of these basics of analysis. So we're looking at a data set here, and this is from the New York Times, which has compiled one of the most extensive data sets. We're looking at our categorical variables, which are our time frame, our date, county, state. FIPS is the unique code for counties that help us kind of keep track of them and deal with the difference that many states have counties with the same names. And then some other summarizations of our time frames. So those are our categorical variables. And then we have our quantitative variables, cases and deaths at the most basic level in population. And then we have our contextual key measures or key performance indicators, things like the percentage of total is going to help us understand proportions. And then our population-based measures such as cases per 100,000, both in the case of cases and deaths. And in this data set, we're talking about cumulative cases since the beginning of the pandemic through the end of September, so last week, September 30th. So what are some of the things that we can do with this data once we have it organized this way? Well, we can very easily sort the raw data and see where the highest number of cases are. No surprises here that they'd be in California, Texas, Florida, New York. Well, those are the largest states, right? That's certainly where we would expect the highest number of deaths. New Jersey is up there, as is Texas, for deaths. But that only tells us so much. It only gives us part of the picture. So if we factor in the population and look at these key performance indicators of cases per 100,000 and sort that, we get a very different picture. We have a state that we didn't see in that other list in Louisiana, and if we did it by deaths, we'd see something different still. So different ways of looking at the same data. The other thing we can do, because this data is highly aggregated at the state level, if we brought this down to the county level, we could conceivably see a very different picture. So we'll go with that same time frame, and this is cumulative data, again, up through September 30th. And we'll start with the FIPS code, and then we'll bring in the county and the state just to give us a better understanding of what we're looking at. So if we sorted cases by county, we're going to see Los Angeles, New York City, the Miami area, the Chicago area. No surprises there. Again, if we do it by deaths, we're going to see very similar patterns. But if we go over to our cases per 100,000 of population measure, we see a very different picture. We see places that don't have a very big population, but they have very high infection rates. Now, you might say, all right, fine, that's focusing in on some areas that have very high infection transmission rates, but we're really not talking about that many people. So what could we do differently there? We might want to look at a similar analysis on a subset of this data where the number of cases is more than 5,000, just to pick an arbitrary number. And then when we sort our cases per 100,000 measure, we see some different numbers. But there are some areas that didn't pop up in our earlier analysis either. Arizona, Texas, Iowa. So there's a lot of things we can do with this data once we have it in this format and we understand our categorical and quantitative variables as well as our key performance indicators. So we talked about these measures or KPIs, and I'm going to use those terms interchangeably because that's how they're used in practice. Metrics is another name for them. But let's take a look at some examples of these and why they're important. So we've already looked at some examples of rates per 100,000 of population, and that's so that we can have this context of understanding what that raw measure would look like per unit of population. Another really important one, as it turns out, in the COVID pandemic are the 3- and 7-day moving averages. And we'll see some visualizations a little bit later that bear this out. But we'll see that there's a huge amount of variation from day to day in these measures. And more than likely, in the vast majority of cases, they are a result of reporting lag, maybe in some cases errors and correction. So it really doesn't make that much sense to look at data on a day-to-day basis. If we average together 7 days, we're going to get a better picture. That will also help us factor out day of the week anomalies. Probably not a whole lot of reporting gets done on Sunday, although there's some, and typically that gets made up for on Monday or Tuesday. Confirmed and probable test rates. Those are the canaries in the coal mine that tell us when confirmed cases and test rates are beginning to climb, because it probably means that infections are on the rise. Case fatality rates. Now, how many of those cases that are diagnosed as COVID ultimately succumb? Excess mortality is a very interesting measure in that it's, in reality, pretty difficult to attribute a particular case to COVID. Medical examiners and physicians do the best that they possibly can, but they probably get it wrong quite a bit. But if we look at excess mortality, which compares, let's say, this year's mortality across the population to previous years, we're probably going to see some very big differences. And a lot of that will be attributable to COVID, either people who succumb to COVID directly or consequences of the pandemic, such as people being afraid to go to the hospital because they'd be afraid of contracting COVID and ultimately dying from, let's say, heart disease, heart attack, or not getting the treatment that they required for cancer. Hospital capacities. What are the healthcare resources that we have to deal with people as they get sick? And then what are the hospitalization rates so we can predict at what point we're going to reach those capacities. So all of these things can be derived from various data sets, the COVID data itself, as well as complementary data sets such as population and in hospital capacity that we can fold into that data. So we've talked about these measures, these KPIs, right? Well, they're not easy to get to. And kind of in a short phrase, effective data governance is essential to both understanding and trust of data, but it's actually very difficult to do. It's a very deliberative process, using the example of debating the Constitution here in the picture. And if you've ever been involved in a data governance initiative, you realize how difficult it is to come to agreement on what it is you're going to measure, how you're going to measure it, and then the definition of what that represents, and then agreeing to use it consistently and have everybody abide by that set of rules. That really is the essence of governance. But there are some examples of it being done particularly well, and I wanted to provide a few of those examples. This comes from an initiative sponsored by the Robert Wood Johnson Foundation and the University of Wisconsin called the County Health Rankings. And it aggregates publicly available information at the county level for all counties in the United States. And most of these measurements are health-related, health outcomes and health factors. So I've got one specific example here of one of the health outcomes measures, premature age-adjusted mortality. So you're like, well, what could that possibly be? And this is actually linked to a web page. So when you get this presentation, which will be made available to you, hopefully by the time that you see this presentation, you can click on it and it will bring you to the website. So we're now actually on the County Health Rankings website and looking at information on that premature age-adjusted mortality. So what are some of the things that you would want to understand about this? Well, first of all, why would you want to use it? It's a common, important population health outcome measure. What are some of the methods used in defining it? Well, it's a rate, it's age-adjusted, it's a rare event, statistically speaking, and what deaths count towards premature death? Well, it turns out that they're counting certain folks, it turns out, under the age of 75. So we're defining, so this is a ratio, so it also defines the numerator and the denominator. How can it be used? So this is how it was intended to be used. And then very importantly, where did it come from? What's the data source? And as it turns out, this is from a very reliable, highly curated data set from the National Center for Health Statistics, specifically the mortality files for the time period 2016 to 2018. So there's typically a lag in this data. So this is part of the 2020 data set, but the most recently available data goes through 2018. And it continues. If you want to dig deeper into the data, here's some examples of where you can go. The CDC Wonder data set, which is an even more extensive and granular data set, would be available to explore that further. So when we talk about data governance and being able to trust data, this is what we're talking about. Very clear definitions, reliable data, trusted, curated data sources. All right, so that was data. Now let's move on to analysis. And there's a few kind of basic, what I consider at least, indispensable statistical concepts that are really important to analysis. Now, these probably aren't going to be new to most of you. In fact, you probably began learning about them in junior high or certainly by high school. So we have first central tendency. That's what statistics call it, statisticians call it. Most of us would call it the middle of the data. And that's measured by things like the mean, the numerical average, the median, the middle of the data set, the middle observation, and the mode. And that's the frequency of slices of the data after we slice it up, the most common observations, if you will. Then we have variation. So if we look at any population, we've got an average, but we don't expect every member of that population to have the same value, right? We expect a certain amount of variation around that middle. And that's measured by things like standard deviation, the interquartile range, which we'll talk a little bit more about in a few minutes, and then variation over time, where there's some very well-defined patterns that tell us when variation is meaningful and when it's not. And then we have the distribution of the dispersion of the population around that mean. So really the pattern of the distribution. And for our purposes, the only thing we care about is whether that is a normally distributed pattern or something other than that. So what does that mean? Let's get into some more detail on that topic. So this is the normal distribution. It's somewhat familiar to a lot of you, bell-shaped curve that represents the shape of a population for a particular measure. You know, so we could think of this in terms of the counties, and one of those measures, like the total cases per 100K of population, we're going to have a middle, the average, the mean, then we're going to have some variation. Now, what does this mean? We have the first standard deviation, second standard deviation, third standard deviation. In this first standard deviation, the majority of the population, 2/3, about 60, 67, 68%, is going to be within one standard deviation of the mean. Now, what does that mean? If we have a value that fits into this area, we know it's pretty common, pretty typical. There are going to be a lot of other observations that have that same value. But if we go out to the third and fourth standard deviation, out into what's called the tail of the normal distribution, we'll see some unusual values. So if we had a crazy value, in fact, we saw something in the neighborhood of like 15,000 cases per 100,000 of population, whereas the typical value is more in the order of 2,000. That's an outlier. We're going to find that way out in this tail. So we can look at that value, that number, and immediately know that it's out in this tail, and it's very unusual. In fact, it may be the product of an error, a measurement error, a reporting error, or it may be for real. We might want to understand it better. We don't want to jump to the conclusion that it's a mistake. But in any case, we know that it's unusual. So this normal distribution, if the data fits us, can tell us a lot about the data and how it's distributed. So let's look at a practical example related to COVID-19. So the mean, so the numerical average of the total cases per 100,000 of population measure across the entire United States as of September 30th was 2,184. All right, that's the middle, right? So what does that mean in the context of all of the data? Well, if we plot the information for the 50 states on what's called a histogram, it looks more or less like that bell-shaped curve. And you know, the normal distribution is more theoretical than real. There's a lot of things in nature that that fit it approximately, but it's very rare that you're going to see an exact normal distribution. So this is close with actually another little subnormal distribution, so it's not exactly normal, but you know, at least we've got the slice of this data set, and these are intervals in the measure. So our 2184 is in this bucket, what's actually called a bin in a histogram, is right about here. So it's in this bin right here, and that's the one with the most observations. In this case, the most states. So more states have a measure in that range of 2,000 to about 2,300 than any other range. So that does tell us some things about the data. It tells us that we've got an approximately normal distribution. But what happens if we look at this at the county level? So we've got 3,100 counties across the US, right? If we plot them on that same histogram, actually a little bit different because we're going to use some different numbers down here, it does not look normal by any means. We've got what's called a skew. And what this is telling us is that there are a lot of counties that have very low case rates, fortunately, in this first bin between 0 and 1,000 per 100,000 of population. And it tails off, as you would expect, on the right side. So what does that mean? Well, a lot of our standard statistical techniques assume a normal distribution. So if we start using things like regression analysis that expect a normal distribution, we can get in trouble very quickly with data like this because it doesn't meet our requirement. Now, there are some games that we can play. We can actually transform our measure using the logarithm, common logarithm, and as a result of that, kind of force this into a normal distribution. And that will actually help us with those statistical techniques. Hey, Daniel, I need quiet, okay? I need quiet, quiet. No noise, I'm recording. So what we have here with a normal distribution is something we can use with our standard statistical techniques. Now, that's not the only solution to this problem. In fact, there's a much simpler way to go about it for basic analysis. And that involves what's referred to in statistical terms as rank and relative standing. It's actually just a fancy name for doing analysis by percentile. Now, this little table right here is called the 5-number summary, and at a glance, it gives us kind of a quick understanding of the shape of the population. So the population that we're looking at has a median value of about 1,600. So that's the middle observation, the 50th percentile. And then we can look at the first quartile, the 25th percentile, and the third quartile, or about the 75th percentile, and see what the values are there. And then the difference between these two, which represents the middle 50% of the population, that's what's called the interquartile range, the IQR. And we can see that that value is, somewhat coincidentally about the same as the median. Not that that means that much. Then we have outliers. We have a maximum value that I just referred to at 15,000. That's way far from the middle. And then equally, we have some minimum outliers. And there's more than just this, but these happen to be the smallest and the largest values in the data set. So one thing we can see here is there's a big difference between the 50th percentile, the median, and the mean. So that probably implies that there's a skew, an imbalance to the overall population. So this fellow right here is John Tukey. He's one of the most famous mathematicians of the 20th century. And way back in 1962, he wrote a paper called The Future of Data Analysis, which kind of envisioned and predicted what we think of now as data science. And it's pretty much come true according to his predictions, and actually using a lot of the work that he did going back into the 50s and before. But part of the premise was that as data becomes more and more available, and in 1962, computers were really in their infancy. There wasn't a lot of electronic data, but that was changing very, very rapidly. And his point was that we use data to support hypotheses or refute them. But in the scientific method, we come up with a hypothesis, then we go out and collect a whole bunch of data, and we use that to do our analysis to support or refute the hypothesis. Once we have more and more data, we're actually going to be able to use that to create new hypotheses. But we're going to need some new techniques in order to do that. So over the course of the next decade or so, he worked on a set of techniques that came to be known as exploratory data analysis. In fact, he wrote a book of the same name in the mid-70s. There were several editions of them where he laid out tools such as the 5-number summary. Now, Tukey was known for a lot of different things, a lot of different innovations. He actually coined the term both bit and software, which are computer terms, but he made probably his biggest mark in the area of statistics. The thing that he's probably known best for is this very simple diagram known as the box plot. And what this does is to help visualize the 5-number summary. So we look at this table and it really doesn't mean all that much to us, but if we make a picture of it, it starts to make a lot more sense. Now here's a box that represents the middle 50% of the data set, the inner quartile, right? Then we've got the median. And sometimes this isn't going to be in the middle. It's actually a little bit off the middle here, but pretty much in the middle. And then we've got our minimums and maximums. And if this is to scale, it helps us really understand the quote-unquote shape of the data. Now, if we superimpose our numbers from our county data set for that total cases per 100,000 of population measure, we can see that a few things. We can see the width of the middle 50% of the population. We can see the difference between the mean and the median, which again implies that there's a skew and imbalance to the population. So great example of using pictures or visualization to help us understand the data. But it's not the only way that we can use these box plots. That first example was pretty simplistic. Here's another example that's using a time series box plot to look at the distribution of that measure, same measure, total cases per 100,000 in population on a month-by-month basis, and this is using the county data. So back in March, we saw that a relatively low infection rate with not a whole lot of variation because there weren't a lot of counties reporting at that point. The infection was confined to a handful of states. And then we move into April, and the infection rate per unit of population moves up, as does the amount of variation. We've got more counties, and we've got more of a variety in the numbers. The rate continues to go up in May, as does the amount of variation. It comes back down a little bit in June, and then jumps way back up in July. So we've got the most variation, we've got the highest median, we've got the highest mean, which is this little dot right here, and the biggest difference between the two. That probably means that there's a lot of counties beginning to report really high infection rates. Comes down a little bit in August and a little bit further in September, with the median coming down a little bit. Interestingly enough, the mean's still a little bit higher. So we could be seeing something different as we move into October. So this is combining the concepts of time series and the box plot to look at not just the middle, which is important, but also the variation around the middle, and also our outliers to understand what might be influencing the population. All right, one more technique in the analysis section has to do with the realm of statistical process control and the variation of data over time. So the concept of statistical process control is that there's always going to be some variation around the middle. And some of that variation is just natural or expected. And we can think of that as noise. Other variation is much more meaningful. And the fellow down here in the picture, Walter Schuhart, came up with this idea while working on telephone manufacturing. He worked for the Western Electric division of the Bell Telephone Company back in the relatively early part of the 20th century. He introduced this idea in 1924, although the work on it had been done in the decade before that. And the work produced a technique or a set of charts that are still very commonly used today, called control charts. And a control chart basically has a middle, what's called a center line, and that's typically going to use the average, the mean, or the median. And then there's an upper control limit and a lower control limit, which is typically some number of standard deviations away from the middle. And we plot our data in a time series. This happens to be day by day, and this is some arbitrary measure. And we're watching it move back and forth, up and down, up and down. And what's happening here is what's considered to be a process under control. It's not doing anything all that unusual. There's just a little bit of variation in what would be the mean of these values down here. But then at some point, things begin to change. In fact, there's a set of patterns that are referred to as run rules, a fairly small number of them, between 6 and 8, depending on which ones you use, that signal when the pattern is unusual or represents something other than just natural variation. In this particular case, it's because there's some number of data points beneath the control the center line. Then here, there's a series of data points with ascending values. This one right here, and all three of these are close to the upper control limit, and this one actually crosses it. So, as we get into this part of the series right here, we've got 4 different run rules that have been triggered. And what does that tell us? Well, it means that the variation that we're seeing in here is something other than what we would expect from normal noise level natural variation. And we can use this to determine when in manufacturing a process is beginning to go out of control. It's typically because a machine is out of tolerance and it's going to begin producing defective parts. So as soon as we see this pattern, we can intervene by either shutting down the line or proactively maintaining the machine. And these concepts have been used in manufacturing for decades now. They're actually the basis for much of process improvement techniques and methodologies such as Lean and Six Sigma. But they've also found their way into other industries, including healthcare in the last few decades. So how do we apply this to coronavirus? So here's an example from New York, and it is the 7-day moving average of our a slightly different measure, the new cases, not the cumulative cases, but the new cases per 100,000 of population in New York State during September of 2020. And you can see very clearly that there are some very interesting patterns here. This is back in the early part of September. We had an increase in the rate, and then it went down, and then it came back up again. Then it kept going up. So we've got a few different things going on here. In fact, we probably wouldn't even want to look at this entire 30-day series because there's so much going on. We'd want to look at specific subsets like this one right here. So as of around September 17th, we can see things start, it looks like things are kind of in control here, and then gradually things start to change. So if we zoom in on that and take a closer look, we can see our process is pretty much in control through here, and then it starts moving upwards. We've got a series of increasing values, and we're actually crossing over the upper control limit here. So we got a pretty good idea that things are going in a different direction than they had been going. Unfortunately, it's not a good direction. And it gives us maybe a little bit of visibility into what may be happening in the future. And lo and behold, the next data point jumps way up, and then the series continuing on, I think, has continued to increase. So we're seeing a little bit of a spike there. So this is a very powerful technique for understanding variation in terms of how data changes over time. All right, so far we talked about data, a lot about analysis. I want to quickly run through some great examples of visualization. And I've got some what I consider to be really first-class examples from 3 different organizations who have been involved in collecting data, analyzing it, and reporting on it. Johns Hopkins, the New York Times, and a data collaboration called Our World in Data. So we're going to look at a few examples from each of these. So the first one is from Johns Hopkins, and you probably hear in the news a lot of information that is sourced from Johns Hopkins, who compiles this data from around the world. So great example of visualization here. This is a dashboard that looks at 3 measures, key performance indicators, in visualizations that kind of help bring them to life. So we've got new cases, tests per 1,000 people, and percent positive for these cases. So these are all related when you think about it, right? New cases, you're only going to identify new cases if you do testing. So what's the amount of testing that you're doing, and what's the positivity of those tests? And we've got that for all 50 states, which is a little bit overwhelming if you look at them all together, but we can get this down to a subset since such as New England. I'm in Boston, incidentally, so I'll use a New England example. So if we bore down into this a little bit further, we're looking at, in the example of, and I'll use Massachusetts, our number of new cases per day. And as I mentioned before, there's a lot of variation day to day here, so we're going to use this moving 7-day average, which is what this line is. The blue sections are downward trends, the orange sections are upward trends, and we summarize this here in terms of what's happening this week versus last week. So in Massachusetts, upward trends in both cases. Test per 1,000 people, kind of a similar chart. We can see how test volumes are increasing or decreasing over time. We've done a lot of testing in Massachusetts, so this is a pretty high number. And then we've got percent positivity. And our trends here are compared to a threshold of less than 5%. So downward trends just means that it's less than 5%, but it actually may be increasing, as in the case of Massachusetts. So a great way of using a matrix of information across 3 related measures across similar geographies. Now, that's kind of dense. There's a lot of information in there. Here's another example that communicates at a even more basic level. You can look at this map right here very quickly and discern some patterns. So what this is showing is that our measure of new cases per 1,000 people, a slightly different measure than we've been using previously. Interesting thing about this chart is that the states are arranged geographically, so the states that are contiguous are next to one another, but we don't try to factor in geography in terms of the relative size of the states. So they're all the same size. That allows us to concentrate on the spatial relationships between the different states. So we can see, for example, here in the northern western part of the country, the northwest, and the northern central states, northern Midwest, there's a pattern here. The Dakotas have an increasing trend in terms of cases per unit of population, as does Montana, Wyoming, and Minnesota. Meanwhile, back in the Northeast, that got hit hard early on in the pandemic, things are on a downward trend. So that was Johns Hopkins. There's a lot more there. Again, when you get this presentation, all you do is click on this link and it'll bring you there. New York Times has compiled a very extensive data set at the county level for the US, and they have a variety of interesting charts. This one right here, which is the 7-day moving average from the beginning, and this one is at the US level, kind of emphasizes the fact that there's a huge amount of day-to-day variation in cases as well as mortality, and there's a similar chart for mortality here. They complement the chart with a very basic, I think easy to understand, kind of tabular view of what's going on in the data. So total number reported on a particular day, and then the 14-day change. Now, there are a few other examples that I think are worth looking at. So this is another map-based dashboard view that's very different from the Johns Hopkins example because it is more spatially accurate. Big states are bigger, and this is organized on a county level, so the data is actually much more granular than what we just looked at. And what you're seeing is that in the West, where there are a lot more counties, but they're much more sparsely populated, there's a much lower case incidence. In fact, all of the gray here, there's no cases at all. Whereas you look at other areas, such as the counties in the eastern part of Wisconsin, there's a very high case incidence, and we can also identify other clusters throughout the country. In fact, some of the other visualizations that the Times reports every day, areas where cases are higher and staying high, where new cases are higher but going down, areas where new cases are lower but going up. We've got some New England states in here, including Massachusetts, and then where new cases are lower and staying low. So some of the areas in the South they're recovering. And the same thing for deaths. So jumping over to Our World in Data, this is a compilation of data collected from Johns Hopkins and other sources that allows us to look at information not just around the US, but around the world. So this is a very useful and innovative chart that kind of interactively shows, in this case we're looking at new confirmed COVID cases around the world on a day-to-day basis. So we can see that the United States just about leads the world on this measure. India and Brazil are the only other countries that are kind of in the same category, and they have much larger populations. And if we do the same thing by confirmed deaths, we actually see a very similar pattern here. India, United States, Brazil, and Mexico. Now, there's a lot of context as we look at these different measures. We can choose another measure like the case fatality rate, which tells a story, but it's a very different story. So here's Italy, which we all know got slammed really hard in the early months of the pandemic, had a very high death rate, as did Mexico. But the US is much further down the list in terms of that case fatality rate, kind of in the middle of the pack here. And that was largely a result of learning from the experience of Italy in particular, but other countries such as Spain that got hit hard early on in the process. And a lot of the measures that have been used to reduce hospitalization and case fatality rates have come out of Italy, as well as the experience of applying those protocols and techniques in the US and other places. This website and the projects within them, very data rich, great examples of visualization. We just have time for this one today, but by all means, check this out. So next we want to look at critical thinking. So all of the work that we've done so far, looking at data analysis, visualization, is all in service of figuring out the problem, right? The critical thinking. You know, if we're not going to put the data to work, there's really no use in doing everything that we've talked about so far. And there have been some very illustrative examples of critical thinking during the COVID pandemic. And I wanted to focus on just a few of these. And this is really just scratching the surface in terms of the innovative critical thinking that's been done. But I wanted to use some examples from early on in the pandemic, in the March timeframe, when things were far from clear, that kind of looked forward to say, this is likely what's going to happen given various scenarios. So we're going to look at infection transmission, herd immunity, vaccine effectiveness is an extension of the other two. I don't have a specific example of this, but if we had time, we could certainly find one. So let's start with infection transmission rates. And I'm going to use an example of from an article that was reported in the Washington Post back in mid-March, which draws on a variety of research as well as basic epidemiology. Not everybody understands basic epidemiology, so this was a great example of explaining some of the basics of what happens during an epidemic or pandemic. And the title is, why outbreaks like the coronavirus spread exponentially and how to go about flattening the curve. So the first section of the article talks about that exponential nature of infection as more people get infected and infect one another throughout a population. And then we got a very basic animation here that shows, what would happen in a population of 5 people with a highly infectious disease like COVID. And what would happen is one person would get it, they would infect the next person, who would infect the next person, and very quickly the entire population of 5 people would be infected. But people recover, so that's not exactly what happens in actual practice. People infect somebody else and then they get better. So if we take those concepts, how could we apply them to an actual population? So this is a simulated population of about 200 people, similar to the population of Whittier, Alaska. And what's happening here is that if we don't have any controls over the spread of infection, we have the entire population eventually getting infected. So at one point, every member of the population is infected, and then they gradually recover over time. That's not a good scenario. We don't want everybody infected at the same time. So what are some of the things that we can do to control or manage that? Well, here's an example of what would happen in a population where a quarantine is in effect, which is what Singapore and South Korea did somewhat effectively. But here's what happens. Quarantine isn't perfect, so more and more people kind of seep outside of the quarantine, gradually infect the rest of the population, and we end up having a fairly significant share of the population infected at once, and then gradually the population recovers and we get immunity. So let's look at another scenario here. So this is what happens when we begin to apply social distancing. And what you're going to see here is that, with some degree of social distancing, we're actually able to control the spread of infection and then balance that out with the recovering population to keep the percentage of the population that's infected at one time to a minimum. And that's the basis for social distancing and why it's important. So to kind of bring this down to the bottom line here, we have renderings of several different populations. The reason this is taking some time to update is every time you come into the site, it actually generates a different simulation, which is kind of neat, randomly. So this is the effect on the population for 4 different strategies or non-strategies. This is the free-for-all, no controls whatsoever. So the entire population gets infected, then recovers. Attempted quarantine, about 50% of the population is infected at once. Moderate social distancing, now we've got fewer people in the population affected at once. And then extensive social distancing, we further reduce the number of people in the population affected at once. All right, so that was one point of view. Let's look at critical thinking example number 2, which is herd immunity. So this comes from an article in the Boston Globe, again, back in March, that was based on research that was done by a group of epidemiologists at Harvard. And again, it uses some great visualizations to make some points around how infection spreads, but also the impact of social distancing strategy. And the point to this article was, we don't know when we're going to get a vaccine, so we can't rely on it completely. What we really want to get to, vaccine or no vaccine, is herd immunity. And that's the idea that enough of the population is infected that there's a natural immunity that develops within the population that reduces the spread of infection. So the premise of this work and what was reported in the article was that if we have 4 different approaches to social distancing, none at all, moderate degree of distancing, reducing the spread by 20%, that's the green line. Another scenario, reducing spread by 40%, and then finally the most aggressive, reducing it by 60%, we have some different behavior here. Now they all converged at about this point. This is with 4 weeks of social distancing. If we move to more social distancing, 8 weeks and then 12 weeks, we're going to see very different patterns here. Now the interesting thing is the free-for-all, no social distancing, we actually cross our herd immunity threshold first, but lots of people are sick at once. That's not a good thing. It's going to overwhelm our healthcare system. Interestingly enough, it's at least the contention of this work that the least aggressive social distancing strategy is going to get you to herd immunity more quickly while having a much lower percentage of the population infected at once. And then our recovery is actually going to be better as well. So we end up with fewer members of the population ultimately affected compared to the other social distancing strategies. Now, I'm not saying I agree with this. It's kind of at odds, I think, with the other example. But these are 2 examples of using evidence, information, and experience to come up with theories that we ultimately prove or disprove in practice. Again, that's the whole idea behind using a hypothesis or coming up with a hypothesis and then substantiating it with actual data. All right. So communication. We've just saw a couple of, I think, good examples of communicating data and analysis, but what can we do to kind of learn from other examples? And I've included 2, I think, organizations, or in both these cases, these are sections of the New York Times that do a great job at interpreting data and telling the story behind the data. There's also an example from Johns Hopkins, which every day they update this, and it summarizes all of the information in the Hopkins website into a 1-minute presentation. In fact, I think they have it down to exactly 1 minute. So I'm going to run that for you. I'm not going to say anything, and I'll let you interpret the information for yourself. See that day-to-day variation in the data. Clusters across the country over time. See them ebbing and flowing. Rising cases across states. and then how the US compares to the rest of the world. And that's it. Tune in tomorrow for more. So I thought that was a very clever way of summarizing all that data very visually in a fairly compact period of time. So as we wrap up, I want to mention all these incredible technical resources that we now have at our disposal. Machine learning and artificial intelligence, which will certainly accelerate discovery, the understanding of this pandemic, so we can apply it to future disease outbreaks, and making progress in terms of vaccines and therapies. But in order for the machines to work, they need data, right? There has to be available data. It has to be trusted, well-defined, reliable. There needs to be transparency in our analytic methods. As I'm sure many of you know, there are a lot of games that you can play with statistics, and it's important to be transparent in terms of the data you're using and the methods that you're applying, and then ultimately communicating your results in a clear and understandable way. And I wanted to use an example that I think demonstrates that this is really happening in the COVID-19 pandemic. For all the tragedy that goes with it, it really does represent an advance in using data to further public health and the techniques and the protocols and the therapies that are used to improve health. So the CDC reports every day forecasts of new cases and deaths. And granted, CDC has been in the news a lot, lots of discussion, debate, and controversy. But where do these numbers, where do these projections come from? Well, the daily forecasts at state and county levels are actually come from a consensus of an ensemble of machine learning algorithms or groups working to build those models across a wide range in academia, industry, and government. And you can see them all here. I mean, they're a who's who of the leaders in these fields. And they're all using the same data. Their methods are totally transparent. This is government-funded work, so it's all out there so that the groups can keep an eye on what one another is doing and look at their results, compare it to their own methods, and continually advance and refine what they're doing. And this is really what John Tukey, way back in 1962, kind of envisioned and predicted. And that's that data could actually evolve as a science, generating hypotheses and then using information to prove them out. This is a great example. So again, this link is included in the presentation. You can go out and take a look at all 32 of those modeling groups and see exactly what they're doing. So as we end up here, if you enjoyed, hopefully you did, some of this discussion, there's more where this came from, as you can tell. This is somewhat my passion, a practical approach to data and analysis. And I've written a series of blog posts on similar topics, including analysis, interpretation, visualization, communication, and more. If you click on this link in the presentation, I'll bring you to my webpage. Then you can go to my articles and see it. And certainly feel free to connect with me on LinkedIn. I'm George Deely. Just search for me. So I wanted to leave you with a few thoughts in closing. And the first is that for all this incredible technology that we have with big data, these almost unimaginable amounts of data, pervasive computing that's available as you need it from the expansive cloud, fast networks that can move gigabytes and terabytes around the world in the blink of an eye, and then machine learning algorithms that are at the core of artificial intelligence. We have all this huge technology, but it really doesn't do anything for us unless we can wrap our minds around it and put it into action. And the basics of that, as we've been talking about, aren't that much different from what Florence Nightingale used to figure out various public health problems in the mid-1800s. It was a combination of curiosity. Nightingale certainly had that in spades. Passion, to stick with a problem once you've identified with it, not give up. Numeracy, that basic set of quantitative skills that we've started talking about today to help understand the data, and then the ability to persuasively communicate your conclusions and move others to action. And I'll leave you with one final thought, and this kind of comes out of my own journey and analysis, and that don't be afraid to think, in the words of Thomas Watson Sr., the founder of IBM. Once you jump into a problem, once you have some data to work with, you'll find that things begin to fall into place. So don't be afraid to get in and just dig in. And with that, thank you very much for your attention, and I look forward to catching up with you in the live version to entertain your questions.